this is an area that's of growing interest to people, particularly in terms of trying to access as much information as they possibly can about their own genetics if they're experiencing what they think might be a genetic-driven condition. There's so much out there. I thought I'd take a few slides to go through the difference between research, clinical and direct-to-consumer testing, as well as a few things that overlap between all of the different areas. So in research testing can be, as Michelle said, we participate in research. If we're seeing clients who have a new condition and there's research going on around the world to try and expand the understanding of that condition, we might offer them the opportunity to consent to enrolling in that research. Some research involves genetic testing, but the goals of research will include a range of outcomes. So it could be doing genetic testing to see if you test everybody with a certain condition for a certain gene, do you find anything there? Is that a new gene that we can use to explain some people with that condition? However, it's really important to check the outcomes of the research that you're enrolling in meet your needs, because not every research study actually guarantees to return genetic results to people. So it could be purely altruistic, so something that you enroll in to contribute to the wider understanding, but it isn't going to give you a result directly at any point. Some research projects will say, if we find something, we'll absolutely return it to you, but we don't know how long that's going to take. We don't know how long this new knowledge is going to take to develop, and we don't know how long this result is going to take to get back to you. So we try and take people through all of those things if it's us that's in offering them the enrolment through whatever research is happening nationally or internationally. But some of these research opportunities are available to people directly. You might see them on social media. They might be offered to you through things like the Mito Foundation or other support groups or community groups that you're part of. So it's just something to keep in mind, is to understand, to always ask what the outcomes are and what you might get out of the involvement. So some examples in Australia and across the world at the moment of different kinds of research projects that people might have come across. Mackenzie's Mission is a research project that's had a lot of investment and attention in Australia recently in the genetic sphere. It's a reproductive research project. So Mackenzie was born with a condition called spinal muscular atrophy, and her parents launched a campaign to try and raise awareness. This is the kind of condition that people don't know that they carry before they have children. And it's not until a child is born with the condition that they realise it's there. There's lots of different conditions that work that way, and Mackenzie's Mission offers people the opportunity to be tested as a couple for around 1,500 different conditions. And they'll find out if they have an increased chance of having a child born with one of these conditions from the project. But there's limited spaces in research projects as well, so not everybody can always get involved when and how they want to. Another research project that people might have heard of is the 100,000 Genomes Project in England. This was one of the very first big, well-funded programs to sequence 100,000 people's entire genomes to go back to that data over and over and over with new questions all the time, and using that amazing source of data to try and answer more and more questions as we learn. So, clinical or direct to consumer? This is really the area that gets a bit confusing, I think. What's the difference between a clinical test offered through a clinical service like the Tasmanian Clinical Genetics Service or the Victorian Clinical Genetics Service, genetic services all over Australia, and something that you can access directly, direct to consumer testing? So some of the big differences are in the laboratories that we use and the kinds of processes that they have to have in place to do genetic testing. So in Australia, they have to be accredited with a certain facility that makes sure that they can give consistent, reliable results about what we ask them to do testing on. Direct-to-consumer laboratories, they're not bad laboratories, generally speaking, but it's the questions that are being asked of the laboratories. And direct-to-consumer tests aren't always performed in clinically accredited laboratories. And even if they are, the next thing I'll talk about is you know, the different kinds of questions that are being asked of the laboratories when it comes to the results. So the data collected in clinical testing and direct-to-consumer testing is usually really different. This is going to get a bit technical, and hopefully we have time for questions if people have more questions. But just to give people a bit of education, I guess, on what to look for in how to tell the difference between legit and not so legit testing. So a lot of direct-to-consumer testing will use something called a single nucleotide polymorphism, or a SNP. We call them SNPs. Or where clinical testing will use something called testing for pathogenic variations. Single nucleotide polymorphisms, as you can see in this picture here, so the little letters are the letters of the genetic code in a particular gene in these 3 people. So in each of these cases, a single nucleotide polymorphism, each of these people has a different letter at that same location in that same gene. Polymorphisms are the kinds of things where all of these genes are working, but they express themselves differently. So these can be things like the variation in skin color, hair color, height. These are single nucleotide polymorphisms. Everything is working. It's just coming out a little bit differently because of the different instructions. A pathogenic variant, on the other hand, is something where there is an actual problem with the gene. The gene no longer works because there's been sometimes a substitution of the code that makes it unreadable to the body. It doesn't make sense anymore. It can't use that gene to make what it wants to make, the proteins that build our bodies. There are other ways that these pathogenic variants so pathogenic variant is the way that we now say mutation. Mutation's not a word that we really use anymore for all sorts of reasons. It's not a really nice word to apply to people's genes or to people themselves. And we also know that mutations can incorporate things like perfectly, you know, unharmful changes, and pathogenic means something that causes a problem. So we now talk about pathogenic variations. So in this case, the gene no longer works, and that's what we're looking for in clinical testing. We're not looking for a different letter that tells us, you know, people with A's more likely to come from England, like ancestry testing. People with G's are more likely to come from, you know, Denmark and ancestry testing, for example. We're looking for things that are affecting someone's health. They've come to us in the clinical service because something isn't right, and we want to know if there's a genetic cause, and sometimes we can find the explanation in one of these pathogenic variations. So the laboratories are different, the data is different, the data interpretation is also really different in direct-to-consumer and clinical testing. So in clinical testing, you have a suite of people whose jobs it is to interpret genetic information into useful clinical information that we can apply to people's lives and management. Data interpretation of direct-to-consumer testing ranges in quality. So I'm not saying that they're all bad. Some of these tests are great. It's just they need to be great at what they're for, like ancestry testing. They're not even that great at that, but we can come back to that. But the data interpretation of some of the tests where people might have experienced being told they have an increased chance of developing a certain disease. Maybe you've done a test that says you're at risk for heart disease. Those are based on single nucleotide polymorphisms, and they're saying people who have the letter G at this location, more of them go on to have heart disease as they get older than people who have an A at this location. They're not saying your G equals cardiomyopathy, an actual diagnosis of a clinical condition right now. So the safety of the results is what comes out of that level of interpretation. So being able to tell you what a result means now and in the future, we do always encounter some uncertainty even clinically, but the safety of returning those results clinically is something that a lot of people have worked on to be as clear as possible. The safety of results returned to you through the pipeline of direct-to-consumer testing is usually up to you to interpret. They'll give you a report. It might increase your anxiety because it says you're at risk of a whole bunch of things, and you won't necessarily know how at risk or when this might happen, if it might happen, who do I talk to about this? The difference between clinical and direct-to-consumer testing can be very hard to tell now. The quality of direct-to-consumer testing language and advertising is increasing. The range of tests that you can get in this forum is increasing. So just for a few moments, I'm going to talk you through some of the ways that you can look out for direct-to-consumer and how valid that testing might be for your clinical cause. Price. So clinical genetic testing has come down a lot in price, but is generally still quite expensive. For example, the couples testing in Mackenzie's mission is funded by the government as a research study, but to access that testing through a clinical laboratory for a couple is around $2,000 at the moment. There are, and I'll come to this as well, there are some legitimate companies where you can get that couples carrier testing, and I'll talk to that in a little bit. But when you see whole genome sequencing for $800, for example, we know that that's a $4,000 test, and there is no laboratory around the world that can apply the interpretation and the clinical safety to interpreting that data for the $500 that they're advertising it for. The language that they use on their sites, this can be really tricky if you are not a genetic health professional that has spent years learning these language. But for example, a company that looked really legitimate on the surface that I was reading up on the other day was talking about how you can see genetic changes down the microscope. You absolutely cannot see your genes down a microscope. That level of zooming in is not possible in a microscope. So those are the things that tell us that they don't have people on board that really understand how this testing works. Does it sound too good to be true? So things to look for: the price, the language. Does it sound too good to be true? If they're offering you the future of your health by reading all of your genes for $500, it is too good to be true. Some of these companies here, like 23andMe and Ancestry.com, they're absolutely fine and legitimate. The SNPs that they use for finding about your ancestry is a bit of fun. It's great information. You can link up with relatives all around the world, but they cannot be relied on for clinical information. 23andMe is not able to be used in Australia. They've gotten into trouble here before. You can still access them by sending your samples overseas. Same with sequencing.com and Orchid. Orchid and sequencing.com are two new players that I've seen around a lot, and these look really good on the surface. These are really hard to tell the difference between clinical and some of these tests. But what you'll notice with what I've screen grabbed from the Orchid test is it's telling you that it can tell you all about your health. It can tell you all about type 1 and type 2 diabetes, obesity, celiac disease. Now, type 1 diabetes, only less than 5% of cases of type 1 diabetes have a clear genetic cause. So how can they possibly be giving you that information? This is where I was mentioning before, the consumer-led or direct-to-consumer testing. Now, this is a subtle difference, but it's important when it comes to clinical safety. So consumer-led are kinds of tests, clinical tests that you can access driven by your desire to access them, rather than needing a referral from your GP or to your specialist, to your genetic service, to the genetic test. These are genetic tests that you can access through your desire to access them, but they are still a clinical grade, clinically safe test. They're Australian based. That's one thing to look for. They provide you access to clinicians and genetic counsellors if you need help interpreting the information. They use clinical testing laboratories. So the websites will say NATA accredited testing laboratory or such and such accredited testing laboratory. They apply clinical interpretation of the results. They don't leave you to fend for yourself. Some examples that people might be familiar with across Australia, this kind of testing is Eugene, Prepare or Sonic Genetics. These are all genetic carrier screening tests, for example. And the online private company that I used to work for is actually Eugene. So we had the same set of qualified genetic counsellors and clinical geneticists working on people's results to return them to them as we would in a public service. So these are consumer-led. That's the difference. They're driven by you. They're not tests that you have to have. They're tests that you have to pay for at the moment because they're not being paid for by a clinical genetic service test budget, but they're still safe